of the medications. Come on. All right, ELOs, same thing, right? So the questions that I'm asking you are always going to be based off of our mechanism of action, adverse effects, all of the good things, okay? These are the medications that we're going to go through as we get through this lecture. Some of these y'all have seen, right? We've seen beta blockers. We've seen calcium channel blockers a couple of times. So now we're going to go into detail a little bit more about them. Y'all have seen me talk about digoxin a lot or heard it in interaction-wise, and now we're going to go again in more detail when it comes to this medication. So a little pre-knowledge check about what do we know. What class of antiarrhythmic is a beta blocker? We're going to go ahead and answer it. Y'all are going to know this later, right? So class 2 for most of them. Now, there is a beta blocker called sotalol, and remember our beta blockers N and LOL. Sotalol is one that is also mainly classified in class 3, and we'll get to that whenever we talk a little bit more about it, but it's a class 3, so it's the one beta blocker that kind of went solo, okay? Sotalol is in 3, whereas all of our other ones are going to be class 2. Dofetilide requires 3-day hospitalization when initiated. So when you start it, it's saying, do you have to put a patient in the hospital or can you just give them the medication and they can go home? So true or false, you can guess. Look at that good guess. So when you look at this, and when we talk about sotalol again, there are some medications that we're going to start that are antiarrhythmics that need to be under your supervision or in a facility that has some type of AED or resuscitation measures just in case things do not work out well for your patient. So that's why we have them in there, and then we load them on the medication, make sure that they can tolerate that medication well. And then what is our what is our mechanism of action for digoxin? Does anybody know what it is? It's a cardiac glycoside, right? And what it does is, we're going to talk about the sodium potassium ATPase, and so it inhibits that exchange that's happening, and therefore you can see where it's again essentially helping us with our rhythm that we have, okay? So increasing intracellular calcium, which can then increase that cardiac output. I think about digoxin as digging deep to get a better squeeze from the heart. So like I told you guys yesterday, when we talk about a lot of the pathophys, those aren't things that I'm going to necessarily be testing you directly on, but having a very small understanding can kind of help us with understanding our meds and kind of what's going on. So when you look at this is an action potential that's happening. And so what happens is you're going to have your SA node stimulate that cardiac muscle, and you're going to have different channels that are going to open and close depending on what phase it's in to create an action potential. So depending on who you talk to and what you're seeing, let me get my pointer. 4 is kind of resting or the start before an action potential is created, okay? So you're at 4, and here is like these little notes are the big ideas of what's happening depending on that phase that it's in, okay? So you have phase 4, 0, 1, 2, and 3. So resting, you're more negative here. You have potassium efflux, sodium influx. Then you have sodium influx in your rapid depolarization. Rapid, it's shooting up quickly. Early repolarization to, again, the goal is going to be essentially to get that membrane potential back down to a negative state for it to be resting. The plateau, where you see the calcium influx, and that's where, when I think about calcium, I think about some type of contraction happening. And then your repolarization, again, efflux, and us getting back to that negative state. And over here, you can see how negative we are because you have your membrane potential down here, -90, right, to +20. And this is where we're seeing, and when we see our contraction, we are in the positives. We're not in the negative at that point. So not going to ask you about all of these, but you'll see when we look at some of the drugs, it's going to tell you like, hey, I'm attacking the sodium channel, or hey, I'm attacking, how the calcium is working. And that's just orienting you to this when you're going through this. Some quick terminology, you have an arrhythmia and a heart block. So arrhythmia, kind of thinking of the heart working like as a symphony, right? Everything needs to be following the conductor. When somebody is not doing that, now we are out of sync. And so you can have any type of arrhythmia occur. There's several different types that we have that could potentially happen, okay? And then worst case, their heart stops, all right? So we can see that. And then your heart block is essentially saying, like, when you have your different routes, and I'm definitely like saying this very simple, so I'm not trying to offend anybody whenever I'm describing stuff, okay? I'm just trying to get y'all to the basic point that I need you to be at for meds. So essentially, whenever you have these impulses, right, that are coming from your SA node, they travel either very slowly, or your heart can create other escape routes depending on what's going on. And you can still have irregular beats that can happen from a heart block, but there's different types of heart blocks that you will see. When I ask you about this on the exam, it's not going to be in the sense of you remembering which type of heart block, as long as you know that there is heart block that some of these meds work in, or that you can't use a medication if someone has a heart block. That's what I want you to focus on, not if it's first, second degree, like what type of heart block, okay? So these are just definitions because you're going to see them throughout. Okay, this is what I care about. These are the meds. So when you look at this, these are going to be all of our antiarrhythmic medications that we have, and we classify them by a Vaughn's Williams classification system. And so you have your sodium channel blockers, class 1A, 1B, 1C. So sodium is class 1. Your beta blockers are class 2, except for the one that I told you about, which was, what was the name of that one? Sotalol went solo, right? And it's over in class 3 with mainly our potassium channel blockers. So your Sotalol does have beta blocking activity, but it has a lot more action on the potassium channel. So that's why we see that one over here. And then your calcium channel blockers that you have are your class 4. You see verapamil and DILT that we'll talk about, and we'll break up our calcium channel blockers again into our DHP and our non-DHP, because remember, we have 2 different types of calcium channel blockers. So this is just a good summary for you to see what class everything is in, and if you want to write little specific things off to the side about some of these meds, you could also do that with something that's built like this. So when we talk about our medications and kind of what we're targeting and how they work, a lot of these drugs that we're looking at are going to control different ions that are going to be affecting the rhythm of our heart, right? Because that is the big thing that we're worried about. So when you look at some of these medications that we use to fix our arrhythmias, what you'll see is that some of them can also cause arrhythmias. So we could say that they're pro-arrhythmic. And a big thing and a big study that we had was the CASH trial, so cardiac arrhythmia suppression trial. And that's where we saw, like, hey, this is where we can see a lot of our drugs could potentially be very harmful to our patient, depending on the dose and several other things. So we now are more careful when we look at them. A lot of these drugs are also narrow therapeutic index drugs, so that means that it's a smaller window for you to mess up. You don't want to mess up in this situation, right? So narrow therapeutic windows. You see those negative inotropic effects. So essentially, I'm trying to slow things down. There's something usually wrong that I need to slow the heart down. Let me get it back in sync. And there are several different ways in which we can do this. A lot of these medications that we're going to talk about are oral. We do have some that are IV as well, some that don't need to be under your supervision every single day, whereas some you might have to, hey, I need you to come in more frequently. I need you to come in so I can monitor the drug levels and make sure that everything is okay with the patient. So CASH trial is something that you might hear about when you're out in phase 2 and be like, oh, that's the stuff that we looked at to try to see if there was an increase in arrhythmias with some of our antiarrhythmic medications. And then narrow therapeutic, negative inotropic effects, and then these are the classes. So when you keep hearing class 1, class 2, class 3, class 4, this is the classification system. The Vaughan Williams classification system is how we're basing or naming these drugs. So when we continue to go through this, I'm kind of, when I'm asking you mechanism of action questions, it's going to be a straight up mechanism of action type of question. Same thing with interactions. It'll just be a direct like, hey, what is this drug interaction? So when you look at this, there's a lot of drugs, but the nice thing about them is that they kind of group together pretty well. So our 4 classes that we have, right? So we already said we had class 1, which was all sodium channel blockers. Now, when you look at this, I'm not going to say inactive sodium channel blocker or potent sodium channel blocker. As long as you know that they are a sodium channel blocker, that is fine. If you see that on the exam, as far as like if I said potent versus inactive, I'm not tricking you, like that is what it is. I'm just putting it for completeness. But if you know it's a sodium channel blocker and that it's a class 1A, 1B, or 1C, that is fine. Okay, I'm not going to make you differentiate between that. And so this is just telling you the clinical effects that are going to happen. And then again, your mechanism of action will be just like this, like telling you what is it doing, okay? What if I gave you a name of a drug and I gave you Sotalol and I said, hey, what class does that fall into? You would be able to tell me that. Or if I said, hey, what's the mechanism of action of Sotalol? You're going to tell me how it works in these 2 different ways. And each one of these will also have a slide that will go into more detail about the mechanism of action as well. I don't need you to look at the clinical effects over here. I'm not going to ask you that way. But when we talk about these and to kind of help you remember, we have McDonald's and we have LOL and we have a banana and we have some milk, okay? So hang in there for 1 second. So sodium, right? McDonald's has salty food, right? So sodium is going to be your McDonald's. And then for your class 2, McDonald's laughs, LOL, because beta blockers end in LOL, right? At class 3, banana, because potassium, right, is how it works. So bananas and milk, calcium in your milk. So you can kind of remember where they're working. And McDonald's is laughing because it's really salty, and then we got the healthy stuff down here, right? So McDonald's laughs at bananas and milk. So potassium, calcium, lots of sodium, LOL, because all of your beta blockers in an LOL, remember your outlier that you have. So again, this is giving you that class, and you see the mechanism happening under here. And now we have the different agents that we have. And then you have the clinical utility. As we go through the slides, you're going to see these listed several times with the utility, and you'll see it again at the end. Some of this will also change because when we talk about, as guidelines change, like we talked about yesterday, you'll see some of these things continue to change also, but teaching you based off of what you're going to see by the time you're taking your test. So this will sometimes not be the same as what you will see potentially in phase 2 or a current guideline. So you have gotten into a great field where you have to always learn. Okay, so this slide, make sure that you know this slide, okay? Only thing that I'm not making you figure out is your result on your parameters here. So like your QRS, your Q2, that's more cards. I'm not asking you that way. So the things that have the boxes around them whenever we're going through this lecture, those are the things that I want you to focus more on, okay? And then the things that you see that are highlighted in different colors are like the big ideas whenever we're going through for the slides. So sticking with our way that we remembered our McDonald's laughs at bananas and milk. So your sodium channel blockers, right? A double quarter pounder. So you have your quarter pounder, quinidine, and disopyramide with lettuce and mayo, lidocaine, mexellatine. And don't forget my fries, please, okay? Flecainide and propafenol. That's why I came here, okay, for my fries, please. Now, your beta blockers, we got those, right, because they all have the same ending. Be careful with your Sotalol, which is in your class 3, but these are your potassium channel blockers. I don't have anything cute to remember those by, but your potassium channel blockers, and then we're going to go over our DHP and non-DHP again. These that you see are us looking at our non-DHP. So when we talk about our DHP, those more so deal with vasodilation, which you're going to learn in a later block. We talk about those more when we're talking about blood pressure and things like that. But when we're looking here this is talking about the heart rate, right? So when I look at my non-DHP, I'm trying to slow down the heart rate. And the two that I have that are my non-DHP are verapamil and diltiazem. Okay, so we'll see those broken up again further. So we're mainly focused on our non-DHP and not so much our DHP. Okay, DHP you're going to use more so for like hypertension, vasodilation, whereas your non-DHP, anything that involves like their heart is going too fast, that is where we see them. Okay. All right. This is a picture showing you again where things work as far as that action potential and kind of what it's hitting. Again, if you just look at this and you want to look at this, not something that is a direct, like I'm asking you a question from this, is just a great visualization of that prior slide. And we're also, when we go through this, I want you guys to keep an eye out for when I'm telling you that something is rate versus rhythm control. Because when we talk about rate control, those are the ones where, can y'all see everything? Okay. When we talk about rate control, those are the ones that are more so looking at like the symptoms that someone is experiencing. So if they're like, oh, I can feel my heart beating really, really fast and it's beating out of my chest, those types of things, we'll use our rate control meds, so like a beta blocker or our non-DHP calcium channel blocker. Whenever you look at rhythm control, those are us trying to like convert someone back into normal sinus rhythm. Okay, we want their heart rate to be back normal. Now there are some times where the patient is like, I've been like this for years, I'm fine, just leave it. And there's other times where you can get them back into a normal sinus rhythm and then they slip right back out. Okay, so it just depends on how symptomatic the patient is. Can we control their symptoms? Absolutely. Can we get them back into normal sinus rhythm? Possibly, but does it always work? No. So this is essentially what I was just talking to you guys about. So this one, we have the Pharm trial. When you talk about cards, cardiologists and people who do cards, they love trials, and they do lots of trials to see what happens. So in phase 2, I wouldn't be surprised if you were on your cards rotation and they give you a lot of trials to read and studies, and that's what dictates how we use a lot of our medications. So this one is, bless you, but I'm not going to ask you about a trial directly, like to tell me what it is about. But I want you to remember the ones that I'm telling you as far as like associating them with something and what we found. So AFib, follow-up investigation of rhythm management, or the Pharm trial. This was just us trying to compare and see, hey, is it better for me to do rhythm control to put a patient back into normal sinus rhythm, or is it better for me to just manage their symptoms with my rate control meds? And again, there was no difference between the two. When you look at this is just, again, looking at, hey, what is the difference between me doing rate control versus me doing rhythm control, the pros and the cons? I will say that our rate control meds are a lot safer than when we're talking about our rhythm control meds. Our rhythm control meds are our antiarrhythmics that are just focused on rhythm control. Those are the ones that are going to require a lot of maintenance from you. And a lot of monitoring as well from you. So just kind of keep that in mind. But again, they're both good. Sometimes we will try here first and then on a rhythm control first, and then end up trying to rate control that patient as well. So you can end up with a combination. So I already told you, easier for us to initiate these. They are cheaper. They are a little bit safer. But the cons is that if I am continuously out of sync or out of my normal rhythm, and I am now trying to create escape routes, right, for my rhythm to get where I need it to go, you can see where they have more remodeling that happens when you're looking at rate control. And remodeling is something that we don't want to happen. Essentially, like, think about when you go and work out all the time, right? If you're working out the same muscle, and let's say you're a person who only does arms and you don't do legs, and you look like a letter Y. That's what I tell my husband. Don't skip leg day, baby, because you're going to look, don't skip leg day. But let's say like you just keep working out this muscle, right? Because my heart is a muscle. So if I keep allowing it to beat quickly, I have remodeling, right? But with my rate control, I'm at least helping that. But what if there's some type of heart block or some other issue that I don't know that's going on? Or if I have a rhythm issue, and my rhythm issue is that I'm beating fast randomly, right? Now I'm going harder as well. I am building that muscle up. That is not a good thing. We don't want a big heart. in that kind of way. We want to have big hearts, but not because we've allowed it to beat so fast that it got big, okay? That is remodeling, that is damage. Those escape routes that they're finding, that is also damaging to you as well. So we want to try to fix those things. Here, if I do the rhythm control, you see that now I can have minimal structural changes, which is good. So they have pros and cons to each way. It just depends on the patient, what the patient wants to do, and you educating that patient as well. Cardiology will be heavily involved in this. You're not going to be like super involved in this process, not much, but you will be managing them likely. The rhythm control strategy, also remember that this might require them to be hospitalized as well, right? So that is more money, especially if I don't have insurance. So think about that as well, depending on what you're going to choose if you do a rate or a rhythm control. Now, class 1 agents that we have, we said that these are going to be our sodium channel blockers. A lot of this focuses on that phase 0 that we had. So you'll see some depolarization happening. So use of our sodium channel blockers is not as popular as it used to be because we have better drugs. But again, we did our trials, and we see, especially with that CASH trial, that they're pro-arrhythmic. So pro-arrhythmic means I already have an arrhythmia, and now you've given me a drug that could also make my arrhythmia even worse. And I could potentially die from that, okay? So people say, well, why are they on the market and why do we still use them? They are still good drugs, but the managing and the closeness that you have to follow your patient is what makes it difficult to use these. So you see these are definitely focused on rhythm control when we talk about them, and we said we have class 1A, 1B, and 1C. So when you look at your 1A, again, I'm not going to split hairs with the sodium channel blocking as far as like if it says, so let me point this to y'all so y'all can see, because I keep saying it. See how this one says inactive sodium channel blocker, but when we were on our 1A, it just says sodium channel blocker. If you know sodium channel blocker for your class 1s, that is enough. I'm not going to split hairs and be like, well, 1A said that it was just a sodium channel blocker, but 1B is inactive and 1C is a fast or a slow, okay? So just understand the basic sodium channel blocker. So our mechanism of action here, 1A, remember this was our quarter pounder, so you had your quinidine and your disopyramide or your Norpace. And what this is going to do is it's kind of trying to increase the ventricular response. So this is why you see that we don't use them as much because of that pro-arrhythmic effect that we could have happen. Lots of different things that are decreased, which we want decreased in this instance when somebody has an arrhythmia. So decreasing the automaticity as well as the conduction or how fast that heart is beating, okay? Looking at who we're going to avoid. This is going to become very important, especially as you get into later blocks in Pharm 2, but you're going to be avoiding in your patient who have decreased cholinergic activity, right? And people who have HFrEF. And we're going to get more into the different types of heart failure, but for now, just remember HFrEF. So that's what this means. Heart failure with a reduced, that's what the R is, ejection fraction, okay? So HFrEF. And then looking at your risk of that pro-arrhythmic response that we were talking about, if someone has AFib or A-flutter, that means that their heart is already going fast. It's almost like it's quivering, okay? And so in these situations, you can potentially see the chance of them having that pro-arrhythmic effect increase, okay? Is that always the case in every single patient? No. It's a potential side effect that can happen, but it is a possibility that it can happen, and it can be detrimental if we don't know that somebody has that history. So you see that we have our rate control agents that we could put on board. So a beta blocker, my calcium channel blocker, or I can do digoxin. So what that would do is if I have something else, right, my person is already predisposed, right, because they have a flutter right here, or atrial fibrillation, which is AFib. So their heart is going fast already. So they have these conditions. So what I want to do is I want to try to slow it down, even if I'm giving a drug that is for rhythm control, because my rhythm control drug has the potential to also increase the rate, okay? So that's why I am trying to slow it down with one of these rate control drugs, okay? All right, this is now going specifically into the drugs that we have. So you have your quinidine. This was one of the first ones that they made in this drug class, and one of the first ones that we use really when we're looking at our arrhythmias. Told you already about the mechanism of action. So any of your atrial or ventricular arrhythmias that your patient can have. Sorry, I just realized something. Hold on. I'll go back to this. So for sophomores, I apologize, and I know that y'all probably already know this, right? But so for you to remember or to think about when I'm saying where something is working, whether I'm saying atrium or ventricle, just kind of go over this picture. So your atrium, how I remember, is A comes before V. So your atrium is at the top and the ventricle is at the bottom. So it's just letting you know where the heart or where our medications are working to slow down a beat in the heart. Okay, sorry. we could thank him. Yes, that's fine. Okay, so that's what you're seeing here. It's saying if there is an arrhythmia that is in the atrium, or if there's an arrhythmia that is in the ventricles, that it can target those areas to slow down that arrhythmia if they have that. So again, these are different types of arrhythmias that someone could have. So this one is your atrial flutter, or you'll see A flutter, and then AFib, atrial fibrillation, and we usually abbreviate this as AFib. And then again, I told you those ventricular arrhythmias. So remember, like we already talked about, we don't use them as much because they're proarrhythmic. And then your interactions. Like I always tell you guys, just remember that these are going to be your CYP substrates, so extensively metabolized by CYPs. So if I have a CYP inhibitor that is on board, now I am messing up the metabolism of my drug. Now the concentration of this drug is increasing because I'm not metabolizing it. So I have more in my system, which now means that I can have more what? Side effects, arrhythmias, bad things, outcomes, right? Because the concentration of this drug has now built up. And I already told you that it was proarrhythmic. I already told you that these are narrow therapeutic index drugs. So now if you put on a CYP3A4 in specific, but I would just say a CYP inhibitor, if you put on a CYP inhibitor, now you have caused this person on a dose that they could have been maintained on just fine to go outside of that therapeutic window, increase the chance of them having an arrhythmia, and what happens if they died, right? So that's why I say, are you directly managing this? Probably not, but could you affect this? Absolutely, okay? So paying attention to anytime you see a patient on any antiarrhythmic, I treat them like I treat pregnant patients. I go to my interaction checker and I'm like, let me put in this drug and make sure that it doesn't interact with everything else that they have, okay? Because these drugs are very, very, very picky. These are our picky drugs, all right? So also you see here, right, the same thing that I was saying, if you have a 3A4 inhibitor or inducer, the inducers are important because now I've metabolized it way too much, right? And if I need it to get my heart back into a normal rhythm, but now my concentration isn't where it should be, is my arrhythmia controlled at that point? No, right? So I'll probably still be experiencing my A flutter or my AFib happening, okay? And then looking at your, it is an inhibitor of CYPs as well. So what I want you to pay attention to is digoxin, because digoxin is something that you could potentially see used with our class 1 drugs. But it is an interaction, right? So increases your digoxin levels and the risk of your dig toxicity, which we're going to talk about, which is not a great thing that happens, but we have solutions for it. But I do want you to remember that it can increase your digoxin concentration if you have that on board, and also increasing, again, warfarin. We saw this yesterday with our drugs increasing, right, that anticoagulant effect, which means that I'm now going to have them bleeding too much. They're going to bruise very easily as well. They cut themselves shaving or something, they're going to bleed for a longer period of time, which could be an issue for us, okay? So remember digoxin and remember your warfarin. All right, adverse effects. Lots of them, right? That's why we don't love these. So nausea, vomiting, diarrhea. Most of the time I tell y'all to ignore it, right? But I gave you a percentage. So anytime you see a percentage next to something, that means that this is a big enough population for us to be worried about it. So remembering these GI issues are going to be kind of important for you. So a lot of our patients initially, whenever they're starting it, and this is why we kind of like to see if we can go slow, see if they can tolerate it, they will experience the nausea, vomiting, and diarrhea happening. You also have something that is associated with higher doses, which is going to be your synchronism that you can have. And it's essentially them having like ringing in the ears. Their skin will be like wet or sweaty, I guess is another way to say it. Bless you. And again, you can see flushing, and some of them will say that they feel warmth because of their skin flushing. We also have these anticholinergic properties that can happen. Again, these are the things that are associated with our higher dose. Anticholinergic, so when we talk about our anticholinergic, again, remember things being dried up. Again, more ringing in their ears, headache, psychosis type things happening. Not a pleasant drug for you to have toxicity with. Looking at your, what we already talked about, right? Proarrhythmic. You can induce a tachycardia as well, which could be detrimental to your patient. So when we talk about those SIPs and when we talk about the interactions, and for you as a PA, even if you aren't the person who initiates this, if you see a person on any of these antiarrhythmics, you're gonna, let me double check. Let me see what's going on, especially if they're the rhythm control. Our rate control, we use them for several things, so we're not as concerned with those. But these rhythm control drugs, you are more concerned. You are going to look these up. Hypotension and syncope, you see that you have muscle weakness or depression of the muscles. So what this is essentially saying, if I already have a disease like MG that predisposes me to having muscle weakness, or they're very flaccid, I can see that increased by me putting this medication on board. And then torsades is, again, just another type of an arrhythmia that could occur that can be deadly. This, we try to make sure that their potassium levels are fine, because their risk gets increased if they don't have enough potassium in their system. So if they are a patient who has hypokalemia, you are more likely to see the torsades happen. If their magnesium is low, more likely to see torsades happen. Or if they're already a person who has a bradyarrhythmia. Bradyarrhythmia is the opposite of like a tachy, right? Tachy is fast and brady is slow. Okay, so here, if they're already slow, right, or if they don't have the electrolytes that we typically see that are helping us with the conduction of the heart, we can see them now slip into having torsades. Some of our medications are also just more prone to causing torsades in some of our patients. Okay, so these things are dose related, big thing, and they're reversible. Okay, so understand these side effects. How much have we been going? All right, so your disopyramide or your Norpace, again, sodium channel blocker, same type of mechanism of action that you're looking at. Your clinical use here, you see your ventricular arrhythmias that are not going to be responsive to your procainamide. We don't really, your quinidine more likely, okay? But this is when you see this, think about refractory, right? It didn't work whenever I tried to use my quinidine, and so that's why I am now trying to resort to trying to use my Norpace, okay? Again, horrible side effect profile. Don't use it a lot because it's still in my class 1A of my drugs. Similar side effects, right? Anticholinergic effects that you can see here. Again, if somebody already has like slowness, any type of Brady type of issue, so negative inotropic effect, could potentially cause heart failure if somebody already has issues with their left ventricular function. So the only way that I would ask this, right, because remember we have no cards experience as a whole is how we're going to take that. Then I'm not, if I said something, it would just be like, hey, it could potentially make heart failure worse in a patient who already has heart failure, okay? Hypertension, syncope, torsades, right? Same things, right? It's the same class, so you're seeing the same exact thing happen. Okay, looking at our 1B. When you hear your 1B, again, sodium channel blocker, specifically inactive sodium channel blocker, we have our lidocaine, lettuce and mayo, lidocaine and mexilotine. Your lidocaine, this one is going to be, when we're talking specifically about arrhythmias, it is IV. How else can we see lidocaine be given, right? We can do patches, we can do topically, right, with lidocaine. When we're talking about when we're talking about arrhythmias, we're looking at the IV formulation of it, okay? So that's why it says IV here. And then looking at your mexilotine, this one is a form of lidocaine that is orally active. Lidocaine has poor oral bioavailability, but this is the one way that we can potentially do it orally, like in a pill. So when we think about that and think about using these, they're used for our ventricular arrhythmias, but also pain, right? Because it's lidocaine. So we can get some pain relief from this as well. When we look at our lidocaine specifically, you see your mechanism of action there again, and then I talked to you already about those ventricular arrhythmias that could happen. So you see ventricular tachyarrhythmia with a pulse. When you guys learn your BLS or advanced, depending on which one you're doing, with a pulse and without a pulse matters as far as what we're going to administer and what we're going to do. So I'm not going to teach you that. I'm just going to stick to the actual medication. So ventricular arrhythmia with a pulse, you see that it can also prevent VFib after a cardioversion. So what a cardioversion is essentially there was something wrong, the heart stopped, you can cardiovert mechanically or you can cardiovert with medication. It depends on what you want to do. Mechanically is like you're shocking a patient, and if you use it with meds, of course, you're giving them some type of medication to try to get them back into a normal sinus rhythm. So when you're looking at this is, again, trying to say, I'm trying to prevent VFib after I get them back into normal sinus rhythm. I want to keep them as normal as possible. So that's where you see us using this. And then an alternative, when you have your pulseless VT, I'm not going to ask you about an alternative. I'm going to ask you about primary things in this situation. So don't focus too much on that. Told you already, in this indication with what we're talking about, we're definitely looking at IV most of the time. Very rarely will you see that IM being used. Short half-life, and we already talked about that first pass effect, which is why we have our mexilotine, which is the oral option. So it's a short half-life medication, meaning it's not going to last that long, right? So if I do have a person who is experiencing an arrhythmia and I can't convert them properly, or they are not staying in that conversion, then I'm going to have to be giving them this and running the drip for them a little bit longer. Looking at your dose, if somebody has CHF, that's chronic heart failure or hepatic disease, again, you're going to talk about heart failure more. We might have to decrease or alter our dose for that patient, okay? Now, looking at your adverse effects. This one, when we talk about cardiotoxic was saying if something is like pro-arrhythmic or not, right? That's what we mean by cardiotoxic, is harming that patient's heart. So less cardiotoxic when we're talking about our class 1 drugs. So if we had to compare 1A, 1B, and 1C, this is our best option that we have to not cause those arrhythmias or the toxicities to the heart. You have CNS issues, so drowsiness, blurred vision, agitation, tremor, all of those things that could potentially happen. More likely to see these with higher doses, but it's still something that can happen. Watch out for your patients who have seizures or a history of it already, because it can also induce or cause seizures to happen. Just remember heart block, right? But 3rd-degree heart block is going to be a contraindication so what that means with a 3rd-degree heart block is that there is a complete block whenever you're trying to do a signal between your atrium and your ventricles. And so it's not going to be able to communicate. And so your heart isn't going to respond how it should to that first signal. And so that's what a 3rd-degree heart block is. But just remember, heart block is a contraindication. And then your interaction, I want you to remember amiodarone, because it is definitely something that you could see used. Your amiodarone could cause your lidocaine levels to go up, which could then be a problem, right? Because now you're more likely to see these CNS effects happen that we don't want to see happen. All right, looking at your mixilotine, we already said this was the oral form of that lidocaine because remember my lidocaine has poor oral bioavailability. So my orally active form of the lidocaine, I'm using this more so to treat my ventricular arrhythmias and my patients who have probably already had some type of heart attack or an MI, okay, myocardial infarction. Off-label, not going to ask you about this, but again, we said that these can be used for those arrhythmias, but that we can also use either of these drugs for pain as well, right? So that's what this is telling you. Your PK parameters, we already talked about this class in general, narrow therapeutic index drug. I am a CYP substrate. I'm also a CYP inhibitor. So depending on what I'm telling you, make sure you know if I throw in another inhibitor or if I throw in an inducer, what's going to happen to my medication. Adverse effects, more GI issues, right? So this is also common for these. More GI issues. I can give my patient, because it has okay oral bioavailability, I can have them take it with food to decrease that GI discomfort that they will experience if they're taking it. And then your CNS issues, same thing that we already saw, contraindication, same, because it's also still a 1B, okay? And then last, before our break, we have our 1C. So again, sodium channel blocker. This one is just one of our more potent ones. Sorry. See that? One of our more potent ones. Again, not going to ask you in this sense, but you see here where I'm using it. My supraventricular, so above the ventricles, and ventricular arrhythmias, but not really used for our ventricular arrhythmias, again, because it's still in our class 1 and it's, bless you, proarrhythmic. So that's why you still see the same thing. It applies for 1A, 1B, 1C. That's why we don't use them often. So supraventricular and ventricular arrhythmias, right? So my atrium is above my ventricles. So atrium and ventricular arrhythmias. And then this is something that's going to be a term that you'll see. This is called the pill in a pocket approach. Not a pill in the car, not a pill at their house, a pill in the pocket approach. Pill in the pocket approach is if somebody is telling you like, hey, I sometimes am walking around and I can feel whenever I'm having my arrhythmia, right? Because some people, they will feel it. Their heart's beating really fast. And what we do is we're like, okay, well, we'll prescribe this medication for you. And when you experience that, you take your pill out of your pocket and you take the medication, okay? It is important to tell your patients not to leave these things in the car or don't leave them at home, because if they're at home and they're at work and they're experiencing this, it's not gonna work. The pill is not in their pocket, okay? And don't leave a loose pill in their pocket because there's lots of other things that are in their pockets, okay? But make sure that no one leaves meds in the car because heat will mess up the medication and the meds won't work how they are supposed to. So always make sure you tell patients to take out meds from their car. Again, we said that we can proarrhythmic, so you can see that it can cause a flutter in some of our patients if we don't give them one of our rate control meds. So like our beta blocker, the calcium channel blocker, or the DIG, it's proarrhythmic, so it can cause those flutters to be worse. Flecainide, propafenolone, which was our fries, please, in our McDonald's. All right. Looking at, let me see how many. Okay, we just got one more. Okay, so flecainide, again, mechanism of action, already went over it. We said that all of these that were in class 1 are more of our rhythm drugs. So rhythm of AFib and flutter if they don't have any structural heart disease. And I will say it just like that because we haven't talked about heart disease or any of that stuff, so it will just say they don't have any type of structural heart disease. We will get into that when we get into an algorithm a little bit later. And again, this is something that I can use, right, for my pill in a pocket approach. Your interactions, again, something that could be used because this is a rate control drug that I could have potentially added on, but what you see here is that my digoxin concentration is increased by 25%. So what that means is now I could potentially, if I do have to pick digoxin for whatever reason to put on board and I didn't want to choose a beta blocker or a calcium channel blocker because of some contraindications, I would need to decrease my dose of the digoxin that I'm giving because I'm expecting for that concentration to go up, right? So that's what that means for you. Metabolized by several different CYPs. Your adverse effects look very familiar to what we're talking about. Patients who have AFib have an increased risk of having a flutter happen to them whenever we put either of these drugs on board. when we are looking at our warning, this was that CASH trial that I told you about as to how we found out. This was one of the actual drugs that they used in that study. Okay, we only looked at 2 drugs in that study, but we applied it to the entire class. We're like, oh, this probably holds true for everybody in this class. Looking at your contraindications, again, we have heart failure, anybody who has coronary artery disease or any type of valvular types of defects, again, because we can cause arrhythmias to happen, so we want to be very careful in these patients. If somebody has had heart failure or already had an MI, we want to definitely avoid this medication if we can, because of the increased risk of heart failure. And then your acute decompensated heart failure is here. We'll talk about all of the different types of heart failure, but acute decompensated heart failure, usually your patient already has heart failure, which means their heart isn't working, their ejection fraction is lower than what it is supposed to be, and when they have acute decompensation, usually they're fluid overloaded, there's a lot of other symptoms that they're going to experience, and we usually will try not to give certain medications when someone has acute decompensated heart failure, but this is letting you know that it could exacerbate or worsen or cause acute decompensated heart failure. And then our last one that we're going to look at before break is going to be your propafenone. So same mechanism of action. This one you see that it is in our 1C, it is not in our class 2 with our beta blockers, but you do see that it has some beta blocking activity, very weak beta blocking activity. This is still our rhythm control. So again, your patients who don't have any structural heart disease, and then supraventricular arrhythmias is what we're looking at. So AFib, A-flutter, right? Supraventricular, so things that are in your atrium. Pill in the pocket approach still because we're in our 1C. Adverse effects that you have, something that's different, right? Metallic taste, GI issues, so like constipation, things like that can happen, nausea, vomiting. Your other adverse effects are very similar to what we already talked about. When you think about the bronchospasm, the bradycardia, the heart block, those are all things that are happening because of that weak beta blocking activity that it has. So these are the same adverse effects that you've seen before when you looked at beta blockers. They're slowing things down. Okay, so my acute decompensated heart failure is because my heart isn't beating how it should, and I'm keeping on a lot of fluid because my heart isn't doing what I need it to do. So bradycardia, heart block, arrhythmia, all of these things are essentially happening from that. Now, your interactions. So your digoxin and your warfarin are going to be increased. I don't need you to remember the percentage, but you see that it is a great increase in the concentration of both of those drugs. And these are things, especially the digoxin, that a patient with an arrhythmia could be on. When you look at your warfarin, it's something that's common in people who have several different issues, but you could see warfarin a lot. Anytime you see warfarin on somebody's profile, you want to go ahead and look it up and do your interaction checker to say, hey, is this interacting with anything else that is on board? Warfarin likes war, okay? It's high conflict all the time. It's interacting with something all the time, okay? So digoxin concentration increase, warfarin concentration increase if I have my propafenone on at the same time. Let's come back at 1:15, please, so we can keep going. Started. Y'all ready over there? All right. So a lot of questions about the rate versus the rhythm. All of your, and I'll talk about it again, but all of your ones, your class ones are all rhythm control. It's going to help with your heart rhythm. When you hear rate control, that's going to be like our calcium channel blockers, our beta blocker, our digoxin. That's going to control the rate, how fast my heart is beating, okay? So they're both essentially doing the same thing. Remember, one is not better than the other, right? It's just two different terms that we use, rhythm control versus rate control, and then thinking about the pros and the cons that we had in choosing either of those. Sometimes one may be more beneficial than the other, and sometimes our patients don't want to be out of that abnormal rhythm. They're okay with it because they keep slipping back into that abnormal rhythm, okay? All right, so class 2 agents. This should be a little bit of a refresher. So we have our beta blockers on board here. Oh, let me start my thing. Okay, so same mechanism that you've already seen before. Essentially what they're trying to do is block those catecholamines, right, from stimulating that heart, and it's going to slow down the conduction. All right, so beta blockers are slowing down the rate. Looking at decreasing the automaticity that they have, lengthening the refractory period. So therefore, if I lengthen that refractory period, I can't, not necessarily can't, this is a soft can't, have another impulse go through to have another beat. So it kind of slows the heart rate down. It controls those symptoms that your patient is going to be experiencing. Okay, here are some other effects that you could see. So prolonging your AV conduction, decreasing your heart rate and contractility is the big idea that I want you to see here. Where you see, except for your ISA agents, we talked about this in Pharm 1. So these are your intrinsic sympathomimetic activity beta blockers that we have. Okay, so what they do is any beta blocker that has ISA or intrinsic sympathomimetic activity, they can decrease blood pressure, and they can also decrease like the resistance to blood flow and maintain a heart rate. So the heart rate essentially, if you're dealing with the ISA beta blocker, is not affected. The net effect is null, is what that means, okay? So that was the one that we had our ACE pin. So ACE butylol, Pendolol, labetalol. There's one more that we don't use a lot. There's one more. But those are our ISAs, and we'll see those listed in your Pharm 2 lecture. Not super heavy on this, I don't think. If it is, I'll have you know here. So clinical rate control. So again, that's focusing on those symptoms that the patient is experiencing, or if you end up giving a class 1 and you're trying to decrease those proarrhythmic response, then I can give them a rate control medication. So that's why I was telling you it's important to remember those interactions, especially if you choose digoxin to be your rate control medication. All right. But these are a lot more patient friendly because we use them in so many places. So I'm using these for my tachyarrhythmias that could be caused by some sympathetic activity. So anything, right, fight or flight that we're talking about. So when I look at my sympathetic activity, I say, oh, I'm sorry, right? Like I had to fight or flight. So with this, that is just kind of helping calm it down. So that's why when we tell people who have like performance anxiety and things like that, they're having tachycardia, right? So their arrhythmia is not normal. So I give them a beta blocker to calm them down so their heart rate slows down. They can breathe a little bit better, right? AFib, aflutter, your patients who have your AFib, we'll talk about this a little bit more, but depending on how long they've been in AFib, kind of think about the heart in AFib or aflutter as you want your heart to be able to squeeze and conduct at a nice pace, right? Because if I can't squeeze, I'm not ejecting the blood out. So I want to be able to get a good enough squeeze to push that blood out so it can go throughout my body. If I'm going too fast, I can't get a good enough squeeze. Or if I'm out of sync, I'm not emptying my ventricles or my chambers in the correct way that I'm supposed to. So what happens is blood will pool in your chamber, and then when you get them back into a normal sinus rhythm, guess what happened to that blood that pooled or clotted? I squeeze good now because I'm back in a normal sinus rhythm, and I throw that clot. And they have some type of cardiovascular event, they have a stroke, what have you, because now I just threw this blood that had been sitting there because my heart was doing this, and my blood pooled, and it coagulated and formed a clot, and now I got it back to doing this, and I threw the clot as well. That's why we say we threw the clot. Now I pushed it out, and now I've caused issues. So what this is saying is your AFib patients should also be started on anticoagulation to prevent them from forming a clot, right? Because that blood is likely going to be stagnant. And sometimes before we do certain rate or rhythm controls in patients who have AFib, we want to make sure that they don't have a clot. There are several different things that we can do, and I'll talk to you guys a little bit about that in a moment. But there are several different things that we can do to make sure that the patient doesn't have a clot before we get them back into a normal sinus rhythm. When we look at our evidence here, it's just telling you, hey, when we put a patient who has had some type of MI on a beta blocker, that it decreases the chances of them having sudden death or having a reoccurrent heart attack. So there are certain things that we do after somebody experiences these cardiovascular events. We put them on meds and then we send them home, and they're on them for a very long period of time, sometimes the rest of their life, depending on how bad their incident was. Okay, so that's what this is telling you. And then prevention of any of those arrhythmias, especially if they're tachyarrhythmias, so ventricular arrhythmias, that could happen post-MI. So these we like on board for our patients who have had an MI. As you saw when we were looking at some of our class 1 drugs, we wanted to avoid them in patients who had an MI, right? Except for when we were looking at our 1B, but we were trying to avoid those patients. So pay attention to that, because you can always have a patient on an exam, your pens, what have you, there's small little details, and you're like, they gave you a patient history and you missed the fact that they had a heart attack, or you missed the fact that they have acute decompensated heart failure, things like that, or they have seizures. So pay attention to those types of conditions, because those are the ones that we're worried about a lot. And then this we're going to talk about again in the next block, I believe, but they should all have, any patient who has had an MI, they should all be on a beta blocker, because again, we have shown that it decreases the risk of sudden death, right? So that's improving their morbidity, mortality, and we want to always be able to do that. So most of the time after someone's had an MI, we'll at least have them on a beta blocker for at least 3 years, and that's like on the low end of things. Looking at our adverse effects, this is a revisit of things that we have already seen before, right? So adverse effects, if I'm slowing everything down, think about everything being low and slow, right? So bradycardia, hypotension, weakness, big one, sexual dysfunction, right? Because I have to have enough blood flowing to have an erection, but if I block that, right, I have hypotension, means my blood isn't flowing very well. Now I have sexual dysfunction. In your patients who have diabetes, asthma, or drug withdrawal, the reason why we're cautious with using these is that they can mask those symptoms in a patient who is also on a beta blocker. So that can become not so great for them. Like if I have a person who has diabetes, I need them to know when their body is not normal, so that they know, oh, I need to give myself more insulin, or, oh, I need to eat more sugar. Okay, so this is something that is a very big thing that we are cautious about. And then looking at our agents that we have, you have your propranolol, your metoprolol, atenolol, esmolol, and your bisoprolol. These are the ones that we specifically use whenever we're looking at arrhythmias. Pay attention to what is telling you non-selective versus selective. So our beta 1 was typically like any of our beta blockers that are A through N, and then our non-selective were usually our O through Z. There's one that's off, but we don't really talk about it that much. And then when you look at your HFrEF, this is something that you're going to talk about later, but there's, again, more beta blockers that we look at specifically for HFrEF. Okay, so there's so many nuances, and there's so many different things that we can use these drugs for. These are very common drugs. These are, again, why we can remember in our head when we're studying for this exam, it's safe. These are our safer drugs when we're talking about arrhythmias and treating our patients who have symptoms from their arrhythmias. Okay, so propranolol, metoprolol, atenolol, esmolol, and bisoprolol, and then understanding what's selective, what's not selective. When you look at your esmolol, we talk about this a lot, and exams like to talk about esmolol because it's one of those ones that has a very short half-life, IV-only medication, whereas a lot of these other ones, we have at least an oral formulation. You do see that we have IV for metoprolol. There's a couple other that we have IV formulations for as well. But our esmolol is one that does not have an oral formulation, okay? So it's only available IV, not something that you would be able to prescribe, right, on an outpatient basis. When you look at your class 3, so class 3 was our McDonald's LOL, right, was all of our beta blockers. That was your ending. Now we're at potassium. So potassium channel blockers, essentially what they're doing, you remember that as your mechanism, but you have a lot of rhythm control when we're looking at this. There are several different effects that you can see on here. The way that I'm going to ask you is just mainly for you to understand that they're potassium channel blockers, understand that these are also still pro-arrhythmic medications, which should be somewhere on. Oh yeah, right here, has the potential to induce arrhythmias, right? So again, our antiarrhythmics are proarrhythmics as well. Sounds contradictory, but proarrhythmic also. Rhythm control, atrial and ventricular, and then our agents that we have, amiodarone, sotalol, right, which was our class 2, has some class 2 activity, but mainly class 3 activity on that potassium channel blockade. Abutolide, dofetilide, and dronedarone are all of our different options that we have here. All of these are rhythm control. So when you're looking at our medications, mechanism of action, potassium channel blockers, you can go in here and look at this. Now, what I want to point out to you is your amiodarone has iodine, and you can remember that because it has IOD in here, right? So your iodine is in amiodarone. If you have a patient who is sensitive to iodine or who is allergic to iodine, you need to be careful with amiodarone because they could also potentially react to this. Again, you see that this has a lot of different action, but its main action is in class 3, and that's why it is mainly classified there when we look at our Bons-Williams classification system. You see that I have alpha blocking, I have heart or chest pain, anti-angina, vasodilatory effects, right? So vasodilation, if I had somebody that I need to open things up and let their blood flow better, right? They have hypertension. And then this is just essentially saying it's slowing the heart rate down, right? Slowing everything down. So my clinical use that I have, pulseless. So remember before when we were saying with a pulse versus without a pulse? Remember that as you go through these, what's pulseless and what they need to have a pulse with. So pulseless VT and VFib, you have your A and your atrium, I shouldn't say A. Your atrium and your ventricular arrhythmias can also be treated, which is what we already set up there at the top. And then preferred in our patients who have heart failure. When we talk about the heart, most of the times when we're very concerned either with clotting or even in heart failure, it's usually the left side of the heart that we are more concerned about than the right. So that's why you guys keep seeing the left pop up, because that is where you can have more issues occur and less of a chance for your heart to, I guess, correct it is the way that I think about it. Because once you get to your left side, where does your blood go after that? Y'all are in cards. Where does it go? To your body, right? It's going out. Whereas if I'm on my right side, at least I can now still go to my left and have some type of recuperation or potentially have symptoms that I could catch before I get to my body or my head, all right, and have more serious complications. Looking at your contraindication, so I said that it has iodine, so if somebody has any type of sensitivity. Hyperthyroidism, when we talk about the thyroid, you're going to see that we are going to talk about iodine, which is where we have different moieties, iodine moieties in our thyroid being made, and so that becomes a big thing. So hyperthyroidism, we don't want to give amiodarone. And then heart block, okay? When you look at your PK parameters, you have PO and you have IV. This becomes very important because depending on your patient and how you're going to load your patient, sometimes we like to give oral more than we like to give IV. But our IV does work quicker, right, because of those PK parameters that we talk about. I don't have to go through the ADME process. You give me IV, it's going straight to where I need it to go versus my oral. But if you think about having to load a patient, which we sometimes do with this, now you're giving them a lot of fluid. And that becomes a problem, especially if I'm sitting in the hospital and I'm not moving around a lot, okay? Because they're probably likely on a lot of other meds too. But looking at this long half-life that you have, these drug effects stay 1 to 3 months after the medication is discontinued, okay? So this is one of those longer half-life drugs, and we'll talk about the side effects, some of which make your patient say, I don't want this because it's making me not be cute, okay? You see I'm a substrate inhibitor of several different CYPs that I have on board, several interactions. So like I told you guys, a lot of these antiarrhythmics, you see them on someone's profile. Before you prescribe something, please go to the interaction checker and look it up. For your exam, clearly we can't use the interaction checker, so I need you to remember these, right? So your CYP inducers that you have and your CYP inhibitors, we said that we were worried about a lot of those. What is very different here is that we don't see PGP being inhibited a lot. So this is something that is abnormal about this drug because you don't have a lot of drugs that inhibit PGP. We don't have a lot of drugs that are also a substrate of PGP. So that's something that's kind of, that is not as common and something that you should make sure that you kind of keep to your brain, because tests like to also ask very random things sometimes that are like the outliers to the normal way. So most of our drugs, we think about CYPs, we think about interactions with CYPs because they're usually metabolized that way or they're a substrate of the CYP. This situation, you see where some of our drugs, we use them to our benefit because if we don't care about the CYPs, we're looking at the PGP. So this is your PGP, your P-glycoprotein. You see that I can increase my levels of my statins, which we talked about yesterday, digoxin, which we're going to talk about today, and warfarin is always in the mix, like I told you. So anytime you see warfarin, it's likely they're causing some type of problem. Good drug, but causes problem. This, just understand, like I told you up here, your statins, I don't need you to remember the maximum dose a day that you can use with those. Digoxin, also just understand that the levels can be increased. So this first bullet is good enough. You don't have to remember the specific details down here. And then looking at your warfarin, because I'm also increasing that, I'm going to want to decrease the level of my warfarin or the dose of my warfarin so that my level can still be within a therapeutic range. We'll talk about that and how we will adjust things based off of that. But this will just cause more monitoring for you. So this top bullet is good enough for you to remember. Increasing your levels of your statins, remembering what your statins were, your digoxin, and your warfarin. And then additive bradycardia. So additive bradycardia is essentially saying if you give any drug that causes bradycardia, so any of my rate control drugs that I could have on board, right, would cause bradycardia. So anything that can cause bradycardia, my non-DHP calcium channel blockers, my beta blockers could also be a potential thing here. DIG isn't as bad, but this could be a thing here. When you're looking at this, now what's happening is I have slowed my heart rate down too much, okay? So additive bradycardia is saying this drug all by itself is gonna slow down my heart rate, but when I add on my non-DHP or if I add on a beta blocker, it's gonna further worsen that, okay? So bradycardia. Now, we said this drug stays into my system for up to 3 months after I have stopped taking it, which is a long time. These are several things as to why we have so much monitoring when we're looking at amiodarone, all right? So your adverse effects are seen in over half of the people who take these medications, which is usually why they stop taking the medication. You have pulmonary issues, liver issues, thyroid issues, their skin can turn blue, gray, they look like a Smurf, and then you have eye issues, okay? Amiodarone is all over the place. All right, so palm. So what you see here is that you have fibrosis that could occur. So you're going to check their lungs prior to initiating treatment, and then you're going to check them at the 6 to 12 month mark as long as they're on this medication to make sure that we're not causing the fibrosis, okay? So radiograph, your PFTs, your pulmonary function tests to see how they're breathing, how their airflow is, essentially. You'll do that at baseline, so you know what you're starting with, what am I working with, and then every 6 to 12 months, or if that person starts to exhibit any symptoms or they report any symptoms to you, you can test before that. Monitor any of these symptoms that you see here. Your liver toxicity, so getting your LFTs prior to, and then every 6 months, you're checking up on them. And then your thyroid, whether it's hypo, low, or hyper, high, you're going to monitor their thyroid. So you're going to do this at baseline, and then you're going to get those levels every 6 months as long as they're on therapy. Their skin, you're going to see it, or they're going to complain to you about it and say, like, I am turning this weird color. So you see this, and it takes a long time for this to go away, because remember I said this drug has a long half-life. So even though this person may be like, I don't want to look like this, I'm ready to risk the biscuit, what do they call it, risk it for the biscuit, he doesn't want to be blue. So he's probably going to stop taking his meds. He still has to wait 3 months before anything happens with his skin turning back to its normal color. Okay. okay? And then their eyes, they can get neuritis, and so essentially what should happen, you should have an eye exam on board baseline and then monitor any type of symptoms that they may tell you. Usually with this, they can do yearly if it's someone who already has like issues, they have glasses, with contacts, whatever. We'll tell them, hey, 6 months, just follow up, make sure that everything is still okay. Okay, so most of these you see, you're doing 6 months for my palm, 6 months for my liver, 6 months for my thyroid, my blue-gray skin, you're gonna see it, my eyes, can I see, okay? So that's all, those were all of your adverse effects, but these are all things that you're also monitoring in these adverse effects, okay? This slide has both. All right, when you look at your genetarone, so your genetarone, derivative of amiodarone, which is why they sound the same, but the difference is that I don't see where I have iodine, right? There's no IOD in this one. So genetarone is amiodorone's little sister or brother. We're gonna be non-gender biased, okay? No iodine, so therefore their thyroid function, any sensitivity to iodine doesn't matter to me whenever I'm using this drug. Mechanism of action is still the same. All of this stuff is still the same as what you saw with your amiodarone. You have your AFib, your A-flutter, less effective than our amiodarone. So this is where you end up having to make a decision. But if there's a contraindication as to why I can't use amiodarone, you can't make me, okay? So my daughter says, nanny boo-boo. So now it makes it more difficult for you. You are now going to have to find something else. So this just means that you have to make sure that you get the right dose on board whenever you are giving the genetarone. They could take it with food because we want that bioavailability to be as high as it can be. I'm already lacking as genetarone, right? I'm already not as good as amiodarone. Now I want you to give me food so that you can increase my chances, increase my bioavailability to where I can have more effectiveness in that patient's body, okay? So they need to take this one with food. Half-life, not as long, right? So that means that those side effects and the monitoring and things that we have to do is not going to be as bad as what we talked about with our amiodarone. And then I'm a substrate and an inhibitor of a CYP. Don't need you to remember exactly which one. So looking at your adverse effects, you see, I told you it looks a lot better. Not as effective, there's a trade-off, right? But it looks a lot better. You don't see that thyroid or pulmonary toxicity. Now what you can see here is those heart failure symptoms being worsened. Now, if it is a person who has acute decompensated heart failure, that is also a problem for you because they are already having heart failure and they are already in a crisis, acute decompensated. They're even more decompensated than they usually are. So you don't want to worsen their symptoms with this medication. So that's why you see the acute decompensated heart failure down here as a contraindication, okay? Because it can worsen it with the drug alone. Your drug interactions, we already said, substrate inhibitors, and then any medication that can increase your QT interval. So we've talked about a lot of those, and I will tell you, like, if it's a drug that causes QT prolongation. When you talk about your PANT, that is something that they definitely hit on. Even on like my pharmacy boards and exams, they like to know that you understand which drugs can cause QT prolongation, because that can worsen things for a lot of people, can be very, very harmful to a lot of people. So you got to make sure that you're understanding that. But for me and what I'm doing, I will tell you like, oh, they have another drug on board that causes QT prolongation, or I will give you their QTC and tell you that their QTC is over 500, which you see right here, over 500 milliseconds. Okay, so if you see any QT that is already prolonged, we don't want to give them the dronedarone. I don't need you to remember the class of heart failure. Just remember if they have acute decompensated heart failure, severe hepatic impairment. We already talked about heart block on a lot of these, right? So if they have heart block, avoid. And then if they are already bradycardic, right? So a heart rate that's less than 50 is slow. They are barely hanging down, okay? It could get lower, but this is slow. We don't want to give them a drug that's going to make it even slower, right? Because now I, again, have that additive effect. Okay, sotalol. So when we look at sotalol, again, this one is the one that still has some of that non-selective beta blocker activity, but more of its activity is going to be in our class 3 with our sodium channel blocking. So that's what you see here and highlighted and bolded, is that it has the non-selective beta blocker activity as well. So you have two different things here, kind of like how our amiodarone spanned across almost every single class, but it was still classified as your class 3. Same thing here when we're looking at isotilol, heavy on the class 2, which is why it ends in our LOL. Your black box warning. When we look at this black box warning for this medication, essentially what it is saying is because of those pro-arrhythmic effects that could happen and potentially having to resuscitate a person, we want to make sure that this is initiated or reinitiated in a hospital, okay, or some type of treatment facility that has the ability to provide and monitor. So monitor their heart and potentially provide those life-saving measures if they need them. My clinical use, ventricular arrhythmias or maintaining AFib or A-flutter. When I say maintaining that AFib or A-flutter, it's trying to keep them to where they are not exceeding what their normal is, because I can have some people who want to stay where they are and I can't convert them. All right, so if I choose to stay there, you're just trying to maintain me, and that's it. Looking at your PK parameters, kind of think about your beta blockers whenever you're looking at these. There's nothing spectacular here. Your adverse effects, same things that we talked about before, but you see here, TDP, this is how we say torsades, right? So this is the same thing, saying that with that torsades that could potentially happen, that is why we're keeping them in the hospital for at least 3 days. It says 1 to 3, but the safe side is to do 3 because I have a potential of developing torsades within that first 3 days of me initiating this medication. So that's why we have them in there, all right? Bronchospasms because of those beta blocking effects. If you remember all of your beta blocker side effects, these are the same things that you're going to see whenever you're looking at your sotalol. Just remembering that initiation is one of the bigger things that you can see here. Contraindication, so uncontrolled heart failure. What is uncontrolled heart failure versus heart failure? I can have heart failure, right? And I can be on meds and everything is controlled. I'm not decompensated or any of that. I am controlled. Uncontrolled heart failure is maybe I have heart failure, but I'm not taking any meds, okay? That was my grandma. My grandma had heart failure, and she's like, I'm not taking that stuff. It's going to kill me faster. And she lived like that for 25 years. And finally, my grandma was like, I had enough. But this is one of those things where that is considered uncontrolled heart failure. There's nothing that's monitoring that patient, right? There's no drug that they're taking. They just have heart failure, and slowly what's going to keep happening is their ejection fraction is going to continue to decline, and eventually their heart will stop working, okay? Bradycardia, heart block, right? QTC prolongation, poor renal function. I would tell you all of those things, and you would say, all right, well, that's contraindicated in that person. They can't take the sotalol. Ibutylide. So our butylide starts with the IV medication that we have that we can use, again, for our patients with arrhythmias. You see here more details about your potassium channel blockers, but when I ask you this is going to be potassium channel blocker. Again, we're focusing on our atrial arrhythmia, so if they're in the upper chambers, we can target with our ibutylide. And then you see your adverse effect is that I could potentially cause my patient to have torsades. Pro-arrhythmic. Your dofetilide. So dofetilide, again, mechanism of action is the same thing. You see that I have AFib and A-flutter patients that could have been cardioverted. And that was another thing. Have y'all talked about cardioversion over here yet? No? So I want to slow down because now we've seen this a couple of times. So when we talk about cardioversion, when I say like mechanical, that's what we typically see in like TV shows and movies and all the things where they're like clear and they shock a patient, right, with our pads. That is our AED mechanical cardioversion. My heart isn't beating how it is supposed to, and you are shocking me back into normal sinus rhythm, hopefully, okay? I can also do this with meds. So this is like when someone is coding, we're pushing certain meds to try to also see if we can get their heart to work again, to stimulate it again. So that is the chemical cardioversion, okay? So you have mechanical and you have chemical, and just because you use one doesn't mean that you can't use the other, right? Because there's some times where we're using chemical and then somebody codes and we have to use mechanical, right? Or we're in a code using chemical and then we still need to use mechanical because they lost the pulse or what have you, okay? So there is a combination that you can use of both. Don't feel like there is one or the other. One is less painful sometimes depending on what medication you use to chemically cardiovert somebody than, of course, being shocked. But we have different options. So when you keep seeing cardioversion, that's what it's saying. So indicated for the cardioversion of someone who is an AFib or A-flutter. Anytime you have a patient who is an AFib or A-flutter, your goal is to get them back into a normal sinus rhythm if they want to be back into a normal sinus rhythm. And if you can maintain that normal sinus rhythm. So that is what it is saying is, I have a patient who presented and I found out they have AFib or they have A-flutter, and I want their sinus rhythm. We agreed, me and the patient, that we want to be back in normal sinus rhythm. So I can use this medication to chemically cardiovert them. So with the medication, I'm going to put them back into a normal sinus rhythm, hopefully. Sometimes it works and sometimes it doesn't work. And then you see I can use it to cardiovert them and to maintain that rhythm. Reserved for my patients who are going to be highly symptomatic. Those are the patients who are usually going to come to you, right? They're going to be tired. Their heart is going to not feel fantastic, and they're going to feel like they're going to literally feel it. So those are the patients who are usually going to come to you anyway. Your PK parameters, nothing that's huge here, but I want you to look at your black box warning that you have. Again, we have that hospitalization. Make sure that we're monitoring those patients for those 3 days, and that we are in a facility that has the ability to bring them back if we needed to, okay? Use mechanical if we need to. Looking at your contraindications, we had less than 40 for our creatinine clearance. Now you're seeing less than 20 for your creatinine clearance, or you have that prolonged QTC over your 440, okay? So again, if I gave them this, I can now be slowing things down too much. Or if they have poor renal clearance, now that means that the drug is building up and my side effects and the chances of them having any of these, where did it go? Any of these adverse effects have increased, okay? So I want to avoid that if I can. Interactions, a lot of them, okay? There's a lot. So when you look at this, your inhibitors, right? This is the same principle that we always talk about with an inhibitor. Because I am a substrate of a CYP, if you introduce a inhibitor of that CYP, now my concentration of my drug increased, right? We know that part. Now, drugs that are going to compete for getting excreted out of my body is different. I'm saying this oversimplify, I only have one way out, right? And so if we're all competing to get on that same road, we have to at some point wait. So your dofetilide half-life increasing, again, increases the risk of you seeing those side effects. So these specific drugs right here are the ones that are more likely to increase the risk of you having an increased half-life of your dofetilide, which we don't want to happen, all right? Torsades, again, you see it here, monitoring post-infusion, but again, for those 3 days is definitely going to be crucial for your patient. And then diarrhea, okay? But this is your monitoring afterwards for sure. They're going to be hooked up to all types of things for you to monitor their heart rate. Anyway, blood pressure, all that stuff, they're going to be in the hospital. All right, calcium channel blockers. So we've touched on calcium channel blockers. Y'all are going to see it again the next block, I believe, like you're not getting rid of calcium channel blockers. So your mechanism of action, blocking that inward movement of your calcium ions. So if you do that, that is going to slow down or decrease the conductivity that you have in your heart. So calcium channel blockers' main output or their net effect is that you have slowed down the heart rate. So your resulted action, slowed sinus rate. When you look at your use, this one is one of our rate controls. Very effective drug that we have that's very good for our ventricular arrhythmias, and then looking at your more effective against reentrants. So when we talk about reentrants, this gets very nuanced, but When you have a reentrant supraventricular tachycardia, essentially what that is saying is your heart has found another way for that pulse to get through, or that current to get through, to try to get an action potential or to get that contraction to happen. So this is what this is saying is it's a pretty good drug to prevent that from happening and keep us in a normal sinus rhythm and not have them experience those symptoms that they will feel from that reentrant conductivity, okay? Cardiotoxic effects. So when you look at these, the higher the dose, the more likely you are to see this happen. So again, we usually don't have problems with these drugs. These are our friendlier drugs that we use for several things. But you can, as you increase the dose, you can see more cardiotoxicity occur. Avoid in your patients who have concurrent beta blocker therapy on board. Looking at your hypotension, potential for that to happen because I've slowed everything down. And then your dizziness, GI, all of that stuff, constipation, understanding that it's worse with verapamil. In your next block, you'll get into more detail with comparing the calcium channel blockers and seeing the effects of that. All right, this is a different type of action potential that you can see. I'm not asking you guys about this, but just so you know, there's a pacemaker action potential. We have our pacemakers in our heart, and then you have the action potential of the actual muscle. Okay, so they're two different types of things, but I'm not gonna ask you in that kind of way, so don't worry. Okay, so looking at our non-DHP, we said we have verapamil and we have diltiazem, right? Verap and dilt, and you'll hear people say this is dilt. This one has more of an effect on your cardiac tissue when you're looking at it compared to your diltiazem. So that's what this is telling you, okay? These are the ones, your non-DHP, that work more on the heart and less on the vasculature. It's not saying that it doesn't work on the vasculature, just not as much, okay? Has lesser effects. When you look at your PK, right, renal excretion, if there is some type of hepatic or renal issue, we will have to dose adjust. And then this one you see for your DILT, it is more of a dilator, okay, more potent dilator, whereas verapamil is more like it's stronger on the heart. Both of these are strong for the heart. This one has more effect on that heart rate than your diltiazem. Your diltiazem has more of a vasculature effect, but it's still a very good one when we talk about the heart rate because it is a non-DHP calcium channel blocker. And then you see your PGP here again. All right, these other classes that we have, these are like your honorary Vaughan Williams classification drugs, and you can remember it by DAM as the DAM, okay, as the acronym, and that's how I remember that we have these that are lagging. So your digoxin, there's a whole bunch of information on digoxin. Digoxin is a highly testable drug, even though it is an old raggedy drug. We test a lot on it because you still see it and it is an effective drug. So when we look at this, we said already earlier in class, right, that it was a cardiac glycoside. And when you talk about that, what it is doing, it is acting on that squeeze, the contraction that is happening. So when you think about, I just realized y'all can't see me. I'm sorry, I've been doing a lot of stuff with my hands just for y'all. Sophomores, my bad. I will come over there and demonstrate and mind dance for you in a minute. But it works on the squeeze, right? So the contraction. So when I think about digoxin, I'm trying to dig deep. Digoxin to squeeze as hard as I can. If I can do that, then I can get that blood out so that it's not static in my heart and clotting, right? It's giving it a less of an opportunity to pool. So positive inotrope inhibiting that sodium potassium ATPase of my cardiac membrane. So this is what we were talking about before. So when you talk about like an action potential, what happens is we push out potassium against its gradient. So that's this ATPase that you see right here. So the potassium is going out against its gradient and sodium is going out against its gradient, which is why we need that pump to help us, because it's not naturally flowing out because I'm going against my gradient. So you're going to need to push me out. So when digoxin inhibits that exchange pump, now what we have is more sodium inside and more potassium inside because I don't have anything pushing it or forcing it out, right? I've inhibited. I am inhibiting the sodium potassium ATPase, right? So now that sodium and potassium is staying inside. Your sodium is inside and now you have some more of your potassium that's going to be outside, right? Because it's exchanging. When you look at what happens here, now you see decreased intracellular potassium, right? Because I kept that outside. And then I have more of intracellular sodium because that stayed inside because my pump is broken. So I can't do my exchange. Now what you see is I also have more calcium inside. With more calcium inside, when we think about calcium, it makes us strong, right? So now I can squeeze more because I have more calcium intracellularly to squeeze. That is my mechanism of dig in my brain, okay? I kept the calcium inside to myself, and now I can squeeze. It's because I covered. I can squeeze harder. I can contract harder, okay? So that's what you see, slightly increasing the cardiac contractility, no increase in my O2 demand. Meaning I'm not having to breathe more rapidly. I'm not trying, like it's not doing anything in that regard, but it is helping my heart beat a lot better. Then your AV node blockade, I told you that we have different nodes. And so essentially what this is saying is it is trying to stop that conductivity so that my heart isn't feeling like it has to beat, right? I'm slowing down the rate. So I'm slowing down that activity and therefore I can slow down my heart rate. I can slow down my conduction, and therefore I have my rate control with my digoxin. That is why it is a rate control drug, because it is slowing down how fast I am now beating in several different ways. I'm messing with this pump, right? My sodium, potassium, ATPase. I'm blocking my AV node, which is the conductor. I'm making that stop as well, okay? So I'm attacking on several fronts, and that's why we use it. It's a good drug. It interacts with everything, and it's a pain, okay? Dig makes you do a lot. This is a picture showing how it works. You'll see that you can increase the tone, which helps you increase the cardiac output that you can have, as well as like what we talked about, that sodium, potassium ATPase, and how your different levels of your calcium and potassium and your sodium are all affected. Make sure that you're familiar with how they are all affected. I'm going to finish the digoxin and then we're done. My voice is going. So with our clinical use, you see that I'm using this in my patients who have heart failure. Heart failure means my heart is not pumping, right? It's not doing what it's supposed to do. It's failing. So my heart failure patient or my patient who has AFib or aflutter, because I'm quivering instead of actually being able to contract. Or I'm contracting but not all the way. So that's why I'm using it in these patients. Looking at your patients who are going to, your PK parameters, great distribution, goes all over the place, good drug that you can have. Looking at your half-life, not horrible, but if you have somebody who has poor renal function, older patients, we do see that these concentrations are a little bit elevated, so we have to adjust our dose accordingly, okay? And remember, this is also a narrow therapeutic index drug. So watching out for these patients are very, very important, because if you don't catch a change in that renal function and that drug builds up, you get dig toxicity, which is not something that you want to have to deal with. And you don't want that to happen on your watch, okay? So kind of what I was talking to you already about, right? Narrow therapeutic index drug. Don't make you remember a lot of ranges. This, I want you to remember this range because you're likely to see this, maybe not by me, but you will see this. I don't know. 0.5 to 1.5 nanograms is where we want to be. So you will pull a dig level and you will see if your patient is within this range, okay? When we talk about the mortality rate of this drug, right, and how it can become very harmful, when you have the mortality rate being decreased if your levels are less than 0.9. Once we get over that, and we get outside of this therapeutic range, you're more likely to see toxicity that could potentially be lethal to your patient, okay? Dosing is individualized. So you know how I told you, as you keep practicing, you're going to come up with your box and you're going to be like, I love these drugs and I'm holding on to just these drugs. And I want to start everybody on this dose. This is not that drug. Everybody gets treated differently because we are a narrow therapeutic index drug. I need to take into account what is happening with Raina. Like what is going on with Bob? What is going on with Norman? Like everybody needs their own individualized treatment when it comes to this, and you are going to monitor them closely. And for you, if you add on a drug, you need to run your interaction checker to make sure that you are not altering something that your patient may be on, digoxin, that's at a good level, and they're in that therapeutic range, and you have knocked them out because you added on something so simple, okay? So individualized. Looking at this, if somebody has heart failure symptoms already, so mild symptoms, you're going to be definitely start low and go slow, okay? So that's where you see this 0.125 to 0.25. If they're elderly, remember, think about me and if I was 80 years old, halfway there, right? Or if they're small, I guess that's also me, because y'all aren't letting me get thick. Remember, we were supposed to let me get thick this year, and y'all didn't do that, okay? So elderly or small, right? And I just need rate control. You're just helping me with my symptoms. Then I am still starting low and going slow because that person is probably very sensitive, right? They have a small body or they're old and they probably don't have great renal function. Both things could be an issue for me because my DIG has nowhere to go. And now you gave me a bigger dose and now you've caused me to have DIG toxicity, okay? Renal dysfunction, I told you already, we have to dose adjust for that. And then your labs, you're going to monitor. Also, I want you to write this in because it is not on there. If somebody has a heart rate that is less than 60, you also need to be careful with this medication. Heart rates are big things that we need to watch out for. That's actually one of the things that's a contraindication because their heart rate is very low, okay? So less than 60, no. DIG is a no-go. And then you're monitoring ECG, your DIG level, your electrolyte level, your BUN, creatinine, lots of monitoring. We don't love DIG, but it's a good drug, and we like to test you on DIG, okay? We'll stop right here because y'all are looking at me crazy, and we got pretty good. So tomorrow, I told the class leaders I would let y'all know if I would only take an hour, and it is possible, just have the next person on standby who's after me because I teach you guys at 10. I don't know if you would want to push something up earlier, your lunch up earlier, but just tell them to be on standby because I have like 30 slides left, okay? All right, see y'all later.